ठीक है। Hi guys, good evening, good evening. Can you all hear me? Can you all see me? I hope I'm audible, I'm visible. Hi Vaishnavi, hi Parmeet Singh, hi Mahek. Hi guys, hi. Good evening guys, good evening. Right, so as planned, quite excited about starting this new journey. We'll be talking about the entire Bailey series. I would like to start with the thyroid so that we can add a lot of components together. We'll go with a clinical scenario. We'll try to understand each and every single concept. So as discussed, we'll start with the today's objective with the thyroid anatomy and physiology. So the current topic that we'll be dealing with will be about the entire context of the thyroid anatomy. So we'll start with the developmental status, and from there we will build up the whole concept that you have. Right now, when we talk about the development of the thyroid gland, that is the first topic that we're going to pick up today. We'll talk about the development of thyroid gland. Now we'll be focusing from the beginning itself, right? Now we all know when the thyroid gland is going to develop, it is going to develop from the primitive foregut. Now take this as a representation of the pharyngeal pouch that you have, the first pharyngeal arch, the second one that you have, the third one that you have, then the fourth one, the fifth is fused, and then you have this, and then it continues across it, right? So these are the pharyngeal arches that you have, right? So for the sake of understanding, I'm just going to number them. This is the first pharyngeal arch, the second one, the third one, the fourth and fifth is fused, and this is the sixth pharyngeal arch, right? Now during the embryonic development, you will notice between the first and the second pharyngeal pouch, there is a small diverticula that is formed, right? Initially, it is going to present to you like a small diverticula, and this small diverticula that is going to develop between the first and the second pharyngeal pouch, this is what we call it as the median thyroid diverticula. This is what we call it as the median bud, you can call it as, or a median thyroid diverticula, you can call it as, whatever you want, right? So this is your median thyroid diverticula is formed. It is the median thyroid diverticula that is formed, right? Now, this usually occurs on the third week of the gestation, right? Now, as the diverticula is formed from the fourth pharyngeal pouch, simultaneously you will notice there are two paired structures are going to sprout. Now, these two paired structures are sprouting from the fourth pharyngeal arch. This is going to be the lateral analgae. This is going to be the lateral analgae, right? Now, as we all know, from the first, between the first and the second pharyngeal pouch, you will see the median bud is going to develop, which is a thyroid diverticula, and a lateral analgae will be started to develop from the fourth pharyngeal pouch. Now, as the age of the embryo continues to grow, what is going to happen? You will notice that this median diverticula will now start to elongate slowly, and that too in a caudal fashion. So you'll see this elongation of the median diverticula in a caudal fashion that is going downwards will now give rise to a duct-like structure. Now this, which was initially like a bud or a diverticula, is now transforming into a tube, and this is now named as the thyroglossal duct. Now this is going to develop into thyroglossal duct. Now as it continues to grow, you see the lateral analgae will also grow towards the midpoint, that is at the center, right? So basically they are friends, right? They have decided they all meet at a common point. So the lateral analgae is going to that point from both the sides, and your thyroglossal duct, which is from a bud, is now formed into a duct, is elongated, and when it comes to the point where the meeting point is there, all three of them, no, they cannot wait, and they go and hug each other, right? They are going to literally hug each other, and when they hug, they all are going to fuse. So the thyroglossal duct will fuse with the lateral analgae, and when the fusion is going to occur, it is now going to give rise to the butterfly shaped gland that we've been waiting about. Okay, so you will, in a simple context, I'll repeat again. Initially, there will be development of a median bud, that is a thyroid diverticula, through which there will be a thyroglossal duct that arises. It is going to go down into the caudal line. That means it grows towards the caudal segment, and meanwhile the lateral analgae are developing, and when they develop the lateral analgae, they are going to combine and they're going to fuse together. Now, once the fusion between the lateral analgae and the thyroglossal duct has happened, this is going to give rise to the desired gland that we want, and that is our beautiful butterfly shaped thyroid gland. It is now going to give us this beautiful butterfly shaped thyroid gland that we are going to have. Vaishnavi, we already have a series on the first year as well. So this is specifically for surgery. It is relevant for all the students who have done the anatomy, physiology, and thereafter. So we're taking it from that context. Hi guys, whoever has joined just now, thank you so much for all the support. Hopefully I'll be able to make a lot of difference in the way we are going to approach the subject. So let's not break the rhythm. We'll continue across, and then एक बार खत्म करके ना फिर आराम से बात करेंगे, ठीक है. So as I was saying that initially the development starts from the median bud. From there the thyroglossal duct arises. It goes and fuses with the lateral analgae, and once the fusion is going to occur, it is now going to give rise to this beautiful gland that we have, which is called as the thyroid gland. Now if I simply label each segment, this is what we call it as the lobe of the thyroid gland, right? So this will be called as the left lobe of the thyroid gland. This we would address as the right lobe of the thyroid gland, and the bridge between these two, is what we call it as the isthmus of the thyroid gland. The bridge between these two is what we call it as the isthmus of the thyroid gland. Now, when you look at the basic orientation, remember the size of the right lobe of the thyroid gland. The size of the right lobe of the thyroid gland will always be bigger when compared to the left lobe. So right lobe of the thyroid gland is bigger when compared to the left lobe. When you look closer into the thyroid gland, you will see there is these septations which are present, which are dividing the thyroid gland into smaller subsets. It is dividing the thyroid gland into the smaller subset, and these smaller subsets are what we call it as the lobules of the thyroid gland. So each individual one would be called as the lobule of the thyroid gland, right? Now within the lobule of the thyroid gland, you have the functional cells. Now the functional cells that you will see here is what we call it as the thyroid follicles. Now thyroid follicles are what we call it as the functional unit of the thyroid gland. Now usually they will fill up nice, right? So the concentration varies from 20 odd follicles per lobule, and around these follicles you have the specialized cells which are being present all across here. Now these specialized cells which are present all across here, these are what we call it as the parafollicular cells, right? Because they're present around the follicles, they will be called as the parafollicular cells, or also called as the parafollicular C cells, right? So look at the orientation that we have just developed. Now, when you look at the component, this is what we call it as the thyroid follicle, and the one which is just around this, this is what we call it as the parafollicular C cells. They are the parafollicular C cells, right? So you have the orientation of the follicles, you have the orientation of the parafollicular C cells. I hope everybody knows that the basic function of the thyroid follicular cell, that they are responsible for secreting the thyroid hormone, that is a T3 and a T4 are the hormones. They will be secreted by the thyroid follicles. What is the function of the parafollicular C cells? The parafollicular C cells are basically going to produce calcitonin. Now, because they produce calcitonin, they are named as C cells, whereas the follicles are going to produce T3 and T4. Now, when you look at the thyroid follicles, one interesting thing about the thyroid follicles that I can tell you about. So, when you look at the thyroid follicles, I will show you two different follicles, and you have to identify that which follicle do you consider to be an active follicle and which follicle would you consider to be as a dormant or an inactive follicle, right? Now, when you look at the orientation in one particular follicle, we have the presentation like this. In one particular follicle, we have the orientation of the cells which are like this, right? So this is one follicular set that we have, and these are follicular cells, and there's a follicular lumen right in the center. On the other hand, we have another follicle which have these particular type of cells. They're tall cells, they're slender, and they're arranged in this particular fashion, right? They're arranged in this particular fashion. Now, my question to you is, can you identify these cells? What cells do you think these are? So in the follicular number 1, what do you think the cells are? In this follicular number 2, what do you think the cells are, right? So this is your follicular number 1, this is your follicle number 2, right? Now, first of all, identify the cells that you have. In follicle number 1, you have this, broader cells, and these are your cuboidal epithelium. These are your cuboidal epithelium. Whereas one, you can see these tall, slender ones. These are your columnar epithelium. These are happens to be the columnar epithelium, right? Absolutely good, Satya. The first one is cuboidal, the second one is columnar. Now the question that I've asked you is, out of these two, which one do you think is an active follicle and which one do you think is a dormant follicle? So you have to pick between the 1 and 2, right? Which one do you think is an active follicle and which one think you think is a dormant follicle? Very good, guys. Very good. I'm getting good feedbacks. Absolutely amazing feedbacks. Good, guys. Keep it going, right? Cuboidal epithelium is seen in active follicles. They're seen in the active follicles, whereas the columnar ones are associated with the dormant follicles. They are associated with the dormant follicles. That means they'll not be able to secrete T3 and T4. As simple as that. Okay? So this is the basic objective behind the follicular orientation. So we learned how the thyroid gland is developed, and once it develops, how does it look and what are its parts in general. And then we spoke about how the follicles are going to be considered as the active as well as dormant. Okay? Absolutely good, guys. Okay? Now, let's talk about the extent of the thyroid gland, a little bit more onto this orientation. Now, let's say this happens to be the isthmus of the thyroid gland, this happens to be the right lobe of the thyroid gland, and this happens to be the left lobe of the thyroid gland, right? Now, you will see the thyroid gland will be arranged in a fashion that it is going to be lying on the trachea as well. So basically, you will notice that the tracheal rings will be present. The isthmus will be synonymously placed. Now the isthmus will be synonymously placed across here. So this is the trachea that is present. Now if I start from the top, obviously you have the hyoid bone that is going to be here. After the hyoid bone, we have the thyroid cartilage. You have the thyroid cartilage. After the thyroid cartilage, you have the cricoid cartilage that is present, right? So between these, you see the hyothyroid membrane is there. You have the thyrocricoid membrane is there. And then you have the rest of the trachea continues across here. So this is the trachea that is there, right? So this is the cricoid cartilage that we're talking about. So these are the tracheal rings that are formed. From here onwards, you see the tracheal rings are present, right? So just to get the orientation right, this happens to be the hyoid bone. This is the thyroid cartilage, and this happens to be the cricoid cartilage. And then you have the trachea, and it is placed right across there, right? Now the question is, first, what is the extent of the thyroid gland? Now the superior pole of the thyroid gland starts all the way from the 5th cervical vertebra to the T1 level. So C5 to T1 is the normal extent of the thyroid gland. This is what we call it as the superior pole. This is what we call it as the superior pole of the thyroid gland. And this is what we call it as the inferior pole of the thyroid gland. This is the inferior pole of the thyroid gland, right? This is what we call it as the inferior pole of the thyroid gland, right? So this is the basic orientation that you have to know. Now, when you talk about the isthmus of the thyroid gland, it is going to be present between the third and the fourth tracheal ring. So it is seen in the third tracheal ring as well as the fourth tracheal ring. So TR stands for tracheal ring. So it is placed. So isthmus occupies between the third and the fourth tracheal ring. It occupies the third and the fourth tracheal ring, right? So this is the surface anatomy of the thyroid gland that you must be aware of. Now, let's move a step forward and try to understand the vascular anatomy of the thyroid gland. Now, when we talk about the vascular anatomy of the thyroid gland, we talk about the blood supply, we talk about both the arterial as well as the venous drainage, right? Now, in the context of blood supply, so talk about the blood supply of the thyroid gland. Now, when you talk about the blood supply of the thyroid gland, take this as the representation of the neck. Just for the sake of understanding, let's say this is the site where you have the thyroid gland, right? So this is the orientation of the thyroid gland that we have. So you have the right lobe, the left lobe, and the isthmus of the thyroid gland. We all know that predominantly the thyroid gland has a dual blood supply. One is going to be the superior thyroid artery, another one is going to be the inferior thyroid artery. Now, to understand this, let's say this happens to be the arch of aorta that you have. Now, from the arch of aorta, you have the brachiocephalic artery, the left common carotid, the left subclavian, and then it continues across here. Now, from this point onwards, you see the brachiocephalic is present here. This is going to go into the right subclavian artery, and then it is going to continue as the right common carotid. So this is how the right common carotid is going to go all the way across here. Now, this right common carotid is going to split into the internal and the external carotid, and this is the bifurcation I'm showing you for our reference. Now, at the same time, you have the left common carotid, which is going to go across here in this fashion. This is going to split into the internal and the external carotid artery in the same line, right? And this happens to be your left subclavian artery, right? Until this point, we all know it. Just for the sake of understanding, I'm just going to label it also. This is the brachiocephalic artery. This happens to be the right subclavian artery. This happens to be your left subclavian artery. This is your right common carotid. So say this is the right common carotid. Okay, I'll just put it here because I don't want to disturb the diagram, and this is your left common carotid. Okay. This is your external carotid artery. This happens to be your internal carotid artery. This happens to be the internal carotid artery. Now, we all know that there are two blood supplies to thyroid gland, the internal and the superior and the inferior thyroid artery, right? So where does the superior thyroid artery arise? Where does the inferior thyroid artery arise, right? Now, from the external carotid artery. Now, we all know there are 8 branches of external carotid artery. It is the first branch. It is the first branch of the external carotid artery. It is the first branch of the external carotid artery that supplies to the thyroid gland, and this is your superior thyroid artery. So the superior thyroid artery is the first branch. It is the first branch of the external carotid artery. Then you have from the subclavian artery, you see there is a thyrocervical trunk that is going to develop, right? So from here you see there is this thyrocervical trunk which is going to develop. Now from this thyrocervical trunk, from this thyrocervical trunk, you have the inferior thyroid artery. So from the thyrocervical trunk, you see the inferior thyroid artery is going to originate, and it is now going to supply to that of the thyroid gland. So the inferior thyroid artery is a branch of, right? So if they ask you the question that inferior thyroid artery is a branch of, it is a branch of the thyrocervical trunk, which itself is a branch of subclavian artery, which is going to supply to the thyroid gland. So for the sake of understanding, I'm just going to quickly label it This is what we call it as the thyrocervical trunk. This is what we call it as the thyrocervical trunk. Now from the thyrocervical trunk, you see this is the vessel that is originated. This happens to be the inferior thyroid artery. So this is your inferior. This happens to be the inferior thyroid artery. Now you have the superior thyroid artery, which is from here. The superior thyroid artery. The superior thyroid artery is a branch of external carotid artery. It's a branch of external carotid artery. Now, interesting thing about this is you will notice that there's a paired gland on the posterior surface of the thyroid gland. These are your parathyroid glands. The blood supply to the parathyroid gland is derived from the inferior thyroid artery. I'm not saying always, but you'll find 80% of the times or 80% of the supply comes from the inferior thyroid artery, right? So on a quick recap, when you look at the blood supply to the thyroid gland, it is supplied by the superior thyroid artery and the inferior thyroid artery. The superior thyroid artery is a branch or the first branch of the external carotid artery, whereas the inferior thyroid artery is a branch of thyrocervical trunk, and that thyrocervical trunk itself is a branch of your left or the right subclavian artery. Is that clear? Right? So this is the first, the basic vascular concept that you need to have. As a surgeon, I should know that these are the vascular territories. Let's be a bit more better. Can we find something more? Now you should also know something which is anomalous, or something you should know which is not usually present or less present. For example, there is an axillary blood supply to the isthmus of the thyroid gland, and that blood supply is what we call it as the thyroid ema artery. You will notice that the thyroid ema artery, supplies to the isthmus of the thyroid gland, and that is derived from the brachiocephalic artery. So this vessel that you can see right in the center, which is I've just highlighted, this is what we call it as the thyroid ema artery. Now this thyroid ema artery, this is what we call it as the thyroid ema artery. Now, thyroid ema artery derives or it arises from the brachiocephalic artery. It derives or arises from the brachiocephalic artery. It is not seen in everybody. Will be approximately 30% of the patients are found to have thyroid ema artery. 30% of the patients are found to have the thyroid ema artery. Okay. So this is the basic blood supply of the thyroid gland. Now, once I know that how it has been supplied, I should now know that how it is being drained. Now, as a surgeon, when you know there's a thyroid ema artery that is going to arrive, especially from the brachiocephalic and supplies to the isthmus of the thyroid gland, I will be extremely careful while dissecting the thyroid gland's isthmus. I will mobilize the lobe. I will take the vascular component, but coming to the isthmus of the thyroid gland, especially on the inferior surface, I will watch out for the thyroid ema artery. Okay. Why it is not present? It is a developmental component. Okay. It is not something which is mandatory, or it's not something that it is not, a patient will not be able to survive without it. ठीक है, ऐसा कुछ नहीं है कि अगर थायराइड ईमा आर्टरी नहीं होगा तो पेशेंट बचेगा नहीं और पेशेंट जिंदा नहीं रह पाएगा, तब तो बॉडी फाइट करती. ये तो बस एक्सरली प्रेजेंट है, हो गया तो हो गया और नहीं हुआ तो नहीं हुआ. इट इज जस्ट लाइक बाय चांस इट इज हैपनिंग. ठीक है, इफ इट इज देयर इट इज देयर, इफ इट इज नॉट देयर इट इज नॉट देयर. नोबडी इज गेटिंग हार्म्ड इन द ड्यू प्रोसेस. ठीक है, सो दिस is the blood supply of the thyroid gland. Now, in the same context, when you talk about the venous drainage, we'll talk about the venous drainage of the thyroid gland. Now, see, thyroid gland has a very vast network of vascularity. So the superior thyroid artery and the inferior thyroid artery branches are enough to vascularize the entire segment of the thyroid gland. Isthmus does not require a specific blood supply. Yes, you can have an axillary supply, and that is what we've spoken about is your thyroid ema artery. Okay. Okay. So now when you talk about the venous drainage, we'll have the same component. So this happens to be the neck of the patient. Let's say this is the orientation of the neck. We'll just shift a bit. Now, same thing. Let's say right in the center, you have the thyroid gland. So both the lobes are present, right? So we're going to talk about how this thyroid gland is going to drain. Now they're going to drain into corresponding internal jugular vein. So let's say this is the internal jugular vein on the right side. This internal jugular vein is going to combine with the subclavian vein. It combines with the subclavian vein together to form the brachiocephalic vein. The same is going to be present on the other side as well, right? So this is the internal jugular vein which is present on the left side. And it is also going to come and combine with the left subclavian artery. Together they are going to form the brachiocephalic vein, and together they are going to open into superior vena cava. So this is the orientation, right? Now there are three veins from which the thyroid gland is going to drain. The first one is going to be the superior thyroid vein. The second one is going to be your middle thyroid vein. This is also the superior thyroid vein. This happens to be the middle thyroid vein. And then you have the inferior thyroid vein. Now the peculiar part about the inferior thyroid vein, that the inferior thyroid vein of both the right and the left, the inferior thyroid vein of both the right and the left drains into left brachiocephalic vein. They drain into the left brachiocephalic vein, right? So for the sake of understanding, if I label them across, this happens to be the corresponding internal jugular vein. So this is your left internal jugular vein. This happens to be the right internal jugular vein. Now this is what we call it as the superior thyroid vein. This happens to be the middle thyroid vein, and this happens to be the inferior thyroid vein. Now all these three veins are going to drain the thyroid gland, and when they drain into the left brachiocephalic vein. This is the left brachiocephalic vein. This is the left subclavian vein. This is the right subclavian vein, and this happens to be the right brachiocephalic vein. And together they open into superior vena cava. Together they open into superior vena cava. Okay. So you need to understand that the corresponding side, so these are the superior thyroid vein which is on the left side. This is the middle thyroid vein which is on the left side. Inferior thyroid vein on the left side. Same thing if you continue on the other side. This is the superior thyroid vein on the right side. This happens to be the middle thyroid vein on the right side, and this is the inferior thyroid vein. This is going to be the inferior thyroid vein on the right side. The inferior thyroid vein on the right side, right? So these are the components which are going to drain the thyroid gland. Okay, so we have discussed the arterial supply as well as the venous drainage of the thyroid gland. Now we'll talk about essentially the nerves which are associated with the thyroid gland, which are going to be important and relevant from the surgical component, right? So talk about the neural component of the thyroid gland. Now the nerves that we're going to talk about we'll be talking about the superior laryngeal nerve and the recurrent laryngeal nerve. Remember, both of these nerves don't supply to thyroid gland, they just pass through them. So hence the proximity to the thyroid gland is what makes them extremely important and for us to understand during the surgery. Now we'll have the same context. Let's say this happens to be the neck. This is a representation of the neck that we have. And let's say this happens to be the thyroid gland that is have, right? Now for the sake of understanding, I will construct the hyoid status. Now let's say from the top you have the hyoid bone which is here. Then you have the thyroid cartilage. Then you have the cricoid cartilage, and from here onwards you have the trachea which has been present across it. Now, from there onwards, you have the suprasternal notch. So I'm just going to stop the trachea here for our better understanding. Now, this happens to be the hyothyroid membrane. This happens to be the thyrocricoid membrane, right? The hyothyroid membrane and the thyrocricoid membrane. Okay. Now, we'll try to understand that how it is going to affect the components. So this is the hyoid, this is the thyroid, this is the cricoid cartilage. So the HTC is what we remember. Okay. Now, let's say this happens to be the arch of aorta that is arising from here. This is going to have the brachiocephalic, the left common carotid, the left subclavian artery, and then it goes across here, right? So this is the brachiocephalic artery. This happens to be the subclavian artery, and then it continues as the common carotid. It's going to split into the internal and the external carotid artery, and this is what is happening, right? The same component is here also. This is the left common carotid. It's going to be internal and external, and this happens to be the left subclavian artery, right? Now, when we talk about the neural component, you see there's a nerve that is going to run along with this channel, right? This is your vagus nerve. This is going across here. So the vagus in the thorax is going to run into the left and the right orientation, right? Now, as the vagus runs in the neck as well as chest, the orientation is left and right. But when it becomes abdominal, no, the left vagus becomes anterior in orientation. The right vagus becomes posterior in orientation. That is called as the mnemonic is we have small mnemonics for these. We call it LAP. Left becomes anterior, right becomes posterior. Now, when you look at the vagus in this context, the vagus gives rise to the superior laryngeal nerve, which is going to split into two. That is your internal and the external branch. It is the external branch of the superior laryngeal nerve that is closely associated with the thyroid gland. Then you have the recurrent laryngeal nerve, which is going to reoccur, that is in a recurrent course, and then goes into tracheo-esophageal groove, and then goes into the vocal cords. Okay. So recurrent laryngeal nerve is going to supply in this particular fashion. Okay. So I'll quickly label them across. So this happens to be your vagus. This is your superior laryngeal nerve. This happens to be your superior laryngeal nerve. It has two branches. In the two branches, this one is the external branch. This is the external branch of the superior laryngeal nerve, and the above one is the internal branch. So this is the internal branch. This is the internal branch of the superior laryngeal nerve. Okay. So it is the external branch of the superior laryngeal nerve which is closely associated with that of the thyroid gland. Then you see this, right? This is your left recurrent laryngeal nerve, and this happens to be your right recurrent laryngeal nerve, right? Did you observe something interesting that has happened? If you observe carefully, the right and the left recurrent laryngeal nerves, they have a different orientation. Like one is, encircling a particular vessel, the other is encircling a particular vessel. Now, I hope everybody is able to get this, that the left recurrent laryngeal nerve, it is going to be recurrent because the course is in a reverse manner. The course is in a reverse manner, but at the same time, you can identify that the left recurrent laryngeal nerve is going to arch through the aorta. So it is going to arching through the aorta. So it loops through aorta. It loops through the arch of aorta. It loops through the arch of aorta. Okay. Okay, Sandeep sir, maza aa gaya. So we have the rock star of the medical education in our session. Say hi to Dr. Ranjit. But I don't know what would a pathologist do listening to a surgical lecture. If you're listening, do answer that. I'm very keen. Hi, Mansoor. Right. On the other hand, when you look at the right recurrent laryngeal nerve, it is going to be looping the right subclavian artery. So it is going to loop through. It is going to loop through the right subclavian artery. It is going to loop through the right subclavian artery, as you can see across here, right? It is looping through the right subclavian artery. Now, as you can see, the nerves are in a different context altogether. Okay, so we have a small banter going on. Ranjit sir has responded. My question was, what is a pathologist doing in a surgery lecture? And he's like, maybe to learn surgeon's mind so that report accordingly. Okay, next time at least pay a little bit more attention so that we get a decent report, right? Don't send us back saying the specimen was inadequate, right? Kindly look properly. Chalo. So this is the course that we have. Now, a couple of important and interesting things that you need to understand when it comes down to this orientation that we have kept. Number one, that in terms of arrangement, the recurrent laryngeal nerve that you have, which is a longer one, is it the right or the left? See, the left is coming from arch of aorta, which is here, and the right is coming from the subclavian artery, which is here, right? So it is on a higher level that you can see across here. So I can say that whenever I talk about the length of the nerve, I can say the left recurrent laryngeal nerve is longer. It is longer compared to right recurrent laryngeal nerve, right? So it is the left recurrent laryngeal nerve which is longer when compared to the right recurrent laryngeal nerve. Okay, so it is having a longer course when compared to the right one. Clear? So this is about the neural component that you should be aware of, right? So we had the arterial component, we had the venous component, and we had the neural component as well. Okay, so we have the medicine guy in the house. So we have Dr. Santosh. Sir, I do understand that if you are attending a surgical lecture, it does make a little bit of relevance. I do not understand why Ranjit sir is attending. I'm so keen. I think he has gone to report some case. He's not responding to us. Chalo. So we completed the arterial, the venous, and the neural component. So let's quickly look at the lymphatics of the neck as well. So we'll talk about the neck lymphatics as well. Now, when you talk about the neck lymphatics, okay, when you talk about neck lymphatics, let's quickly run through that as well. Now, take this as the representation of the patient. Let's say this is the ear that we have. This is the neck and this is the thoracic state. Okay? So let's say this is where you have the sternum which is present across it, right? So there's a muscle. So I'm just going to extend the neck part here. There's a muscle that is going to start behind the ear, that is at the level of mastoid, and then goes and attaches to the sternum. Now this muscle which is running across here, this is what we call it as the sternocleidomastoid muscle. This is what we call it as the sternocleidomastoid muscle. So when you're talking about the head and neck specifically, we should have a thorough knowledge of the neck lymphatics. Okay? Now when we talk about the neck lymphatics, you have one which is present right across here. There's another one here. There's one more subset here. One more is here. One more will be here. You will see one will be present here and one will be here and one will be slightly on the lower aspect. Okay? Now let's try to understand which among the following is given across. Okay? So this is your level 1A group of lymph nodes. Now because it is present right under the chin, this is what we call it as the submental group of lymph nodes. This is what we call it as the submental group of lymph nodes. Then you have one that is present across here. So another one which is present just below the mandible, which will be called as 1B. So between is below the mandibular level. So this is called as the submandibular group of lymph nodes. This is submandibular group of lymph nodes, right? So we had the submental, now it is the submandibular group of lymph nodes, that is a 1B. Then you have, this is your level 2. Level 2 is considered to be as the upper jugular group of lymph nodes. This is the upper jugular group of lymph nodes. Then you have the level 3. Level 3 is considered to be the middle jugular. So we had the upper jugular, then you had the middle jugular, and then you have the level 4, which is going to be the lower jugular group of lymph nodes. Level 5 is present on the posterior triangle. It is present on the posterior triangle lymph node. And then you have the level 6, which is one of the very important ones, especially in terms of thyroid cancers. So this is your level 6. The level 6 is the central group of lymph nodes. It is the central group of lymph nodes. And right across here you have the level 7, which is the mediastinal group of lymph nodes. Level 7 is the mediastinal group of lymph nodes, right? So these are the various subsets of lymphatics that we have, right? So we have the level 1A, which is submental, level 1B is submandibular, then you have the upper jugular, middle jugular, lower jugular, and then you have posterior triangular lymph node, then you have the central, which is between the two sternocleidomastoid muscles, and the mediastinal group of lymph nodes, right? Now the level 2 group of lymph nodes, they can further be divided into two subcategories, that is 2A and there will be 2B. Now this 2A and 2B is on the basis of spinal axillary nerve. Now 2A is present anterior to spinal axillary nerve. They are present anterior to spinal axillary nerve, and 2B is going to be present posterior to spinal axillary nerve. Posterior to the spinal axillary nerve. Now in the same context, we have level 5 also have two subsets, that is 5A is present, 5B is present. The 5A is along the spinal axillary nerve. It is along the spinal accessory nerve, and the 5B, it is going to be along the transverse cervical artery. It is along the transverse cervical artery. It is along the transverse cervical artery. Right? Now, why do you want to know all these levels of lymph nodes? Because there are specific drainages which are present. For example, when you talk about the level 6, which is a central group of lymph nodes, now these are the lymph nodes which will be drained for your thyroid malignancies. So whenever you're doing a thyroid surgery, you have to remove the level 6 if it is involved. Now, here is an important thing. When you talk about the neck dissection, especially in terms of malignancies, removing the thyroid gland alone is not important. You have to remove the lymph nodes if it is involved, and then that is why we have to understand the subsets of these lymphatics to remove, whether you're removing a central group of lymph nodes. Like for example, if you're doing a modified radical neck dissection, we remove level 1 to level 5, right? If you're doing a central neck dissection, you remove only level 6 group of lymph nodes. So to have this knowledge and then apply surgically is quite important for us. Okay? I hope everybody is clear up until now. Any questions, guys? Right. So this was the initial orientation of the anatomy that we should know with respect to the thyroid gland. Okay. Tomorrow we are going to continue and we'll take the physiology and the other part of the thyroid gland, which you have a bit of neck anatomy, will touch a bit more, and then we'll go with the physiology and the abnormal physiology in terms of thyroid per se, right? So this was the first day of our Bailey series. It has to be on a consistent level. We have to do on a daily basis, and every day we'll learn a bit by bit by bit. And every day as we learn, we'll improve and we'll only get better from here, right? So if you have any questions, any queries, please do reach out. Anytime you want to ask any questions, you want to connect it personally, any queries that you have my Instagram handle, which is called as the surgery guy. This is by me, that is going to be your Dr. Sandeep Serum Reddy. So we can look up for this. It's a ready with an I, right? So if you have any questions, any queries that you want to ask, you can reach out on this. Okay. So you have the same thing on the Telegram as well. So any questions, any queries, any discussion, any suggestions, open to all. Thank you so much for all the love, guys. Thank you so much. Yes, we'll be we'll be sending you the soft copies as well. Do join the Telegram group for the soft copy. The Telegram group is again by the name The Surgery Guy. It's an open group. You can find there. You'll already see a tons of surgery material is already been floated across here. Right. So thank you so much, guys. Hope to see you tomorrow again. We'll continue tomorrow. Pick up at the same time. That is going to be 9 p.m. to 10 p.m. and build it from there. Have a good night. Thank you so much for listening patiently. Do let us know how did you feel. Thank you, guys. Bye. Thank you. Thank you. Thank you, guys.